Good morning, everyone. This is Dr. Shilpa Garg, Assistant Professor, Department of Anesthesiology, Sri Lakshmi Narayan Institute of Medical Sciences, Puducherry. Today, we are going to discuss a class. Topic is spinal anesthesia. First of all, what is spinal anesthesia? Spinal anesthesia is the regional anesthesia which is obtained by blocking the spinal nerves in the subarachnoid space. As you can see in the picture, this is a basic picture of spinal cord showing the subarachnoid space in which the needle is entering, through which we administer spinal anesthesia in simple words. Next, some words about history of spinal anesthesia. First of all, there was a scientist called Corning in 1885. Accidentally, he administered cocaine intrathecally. Quinky, very commonly used name in spinal anesthesia, 1891, Quincke made use of spinal puncture for diagnostic purposes. August Bayer, another popular scientist in anesthesiology, of Grisfeld, Germany in 1898, introduced the technique of spinal anesthesia. Pitkin popularized the method of introducing agents intrathecally. Next, we'll discuss some basic spinal column anatomy. Basic structure in spinal column is vertebra and intervertebral discs. What are the various parts of vertebra? As you can see in the picture here, vertebral body, then two anterior pedicels, two posterior laminae, transverse process at the junction of pedicels and laminae, then spinous processes just at the joining of the laminae, and next is the intervertebral disc. Spine is composed of vertebral bones, as we all know, and these vertebrae are connected by a fibrocartilaginous intervertebral discs. There are 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 to 5 coccygeal vertebrae. Vertebral column has 2 primary curves, as you can see in the picture. 2 curves which are concave anteriorly, that is thoracic and pelvic spine. 2 secondary curves which are convex anteriorly, that is cervical and lumbar. All the cervical vertebrae are horizontal except for the last, which is slightly inclined downwards with progressive increase in angle of inclination of the vertebrae as we move down the spine. Some anatomy of ligaments. There are 3 major ligaments in spinal cord: supraspinous, interspinous, and ligamentum flavum. Supraspinous ligament is a strong, thick, fibrous band which connects the apices of the spines from 7th cervical to the sacrum. Above C7, what happens? It blends with ligamentum nuchae in neck and attaches to external occipital protuberance of the skull. Interspinous ligament, as its name suggests, it connects adjacent spines. So this ligament is thin, fibrous, and these fibers are membranous and they extend from apex and upper surface of the lower spine towards the root and inferior surface of the lower vertebrae. Again, here is a picture demonstrating all the 3 ligaments. Next is most important ligament, ligamentum flavum. It consists of yellow elastic tissue. The fibers are perpendicular in direction. Now, where do these fibers extend? These extend from laminae from the anterior inferior surface of the upper lamina downwards to the anterior superior surface of the lower lamina. It extends throughout the spinal cord, that is from foramen magnum to sacral hiatus. Although it is portrayed as a single ligament only, but originally it is composed of 2 ligaments, one on the right and one on the left, and they join in the middle, forming acute angle with a ventral opening also. Now this table shows you the ligament thickness, distance to dura, and skin to dura distance, that it varies according to the vertebral level. Like in lumbar spine, the distance from skin to ligamentum flavum is around 3 to 8 centimeters. And in caudal, this distance is highly variable. Similarly, the thickness of ligamentum flavum also varies according to the spine. In cervical spine, this thickness is around 1.5 to 3 mm. In thoracic spine, this thickness is around 3 to 5 mm. In lumbar spine, this thickness is around 5 to 6 mm. And in caudal spine, this thickness is around 2 to 6 mm. Next, we'll discuss about meninges of spinal cord. As these three meninges cover brain, they cover spinal cord also. Dura mater, arachnoid mater, pia mater. Pia mater is a layer that is firmly attached to brain and spinal cord tissue. So the outermost layer is dura mater. It forms a sac around the spinal cord, and it is a continuation of cranial dura mater only. It extends from foramen magnum to S2 vertebra. It is a potential space between dura mater and arachnoid mater, which is called as subdural space, and it contains a small amount of serous fluid. Next layer is arachnoid mater. It is a delicate structure, non-vascular structure, and it is attached to dura. So dura mater and arachnoid mater, they are very closely attached to each other. So dural puncture, as it is separately felt during spinal anesthesia, arachnoid puncture is not separately felt because both the layers are very closely packed. Next is pyometer, highly vascular thin membrane, which covers the cord, and it is very closely attached to the brain and cord tissue. Next is the subarachnoid space. This is the space which is lined externally by arachnoid mater and internally by a pyometer close to spinal cord. Although spinal cord ends at L1 in adults, this space, it continues to S2. How? We will discuss this in embryology. What are the contents of subarachnoid space? Subarachnoid space contains CSF, spinal nerves, trabecular network, blood vessels that supply the spinal cord, and lateral extensions of pyometer and dentate ligaments which supply lateral support from the spinal cord to dura. Now, what about the shape of subarachnoid space? Shape is annular in cervical and thoracic region and circular in lumbar region. Now let's discuss about blood supply of spinal cord. Spinal cord is supplied via two spinal arteries, anterior spinal arteries and posterior spinal arteries. Anterior spinal artery arises from vertebral artery, and posterior spinal arteries, they are arising from posterior inferior spinal artery. Some important discussion about posterior spinal artery. Anterior spinal artery is reinforced by many arteries, of which artery of Adam-Kiewicz is very important, also called as arteria radicularis magna. Now, it can enter anywhere in the cord between T5 and L2, and mostly it enters from the left side. That is in 75% of the cases. And damage to this artery can lead to profound cord ischemia and paraplegia. So, this is a very important branch of anterior spinal artery. Now, something about embryology. Changes in position of spinal cord during development of the fetus. In third month of development of the baby, spinal cord extends the entire length of the embryo. And the spinal nerves, they pass through intervertebral foramen at their level of origin. But with increasing age, the vertebral column and dura mater, they lengthen more quickly than the neural tube itself, and the terminal end of spinal cord then gradually shifts to a higher level than the vertebral column. So at birth, the end of the cord is located at the level of L3 vertebra, whereas in adults, the cord will end at the level of L1 to L2 vertebra. Below this point, CNS is represented only by phylum terminale internum, which is basically the tract of spinal cord regression. And the nerve roots, all the roots of lumbar and sacral nerves, which are present below this terminal end of the cord, they are collectively termed as cauda equina. Why this name? Because they closely resemble a horse's tail in shape. So the spinal cord, in conclusion, we can say spinal cord ends at L3 at birth and reaches L1 by 6 to 12 months. The dural sac is at the S4 level at birth and reaches S2 by the end of first year. The line joining the two superior iliac crests, that is intercristine line. We'll discuss this later. This is a very important landmark. It crosses L5-S1 interspace at birth, L5 in young children, and in adults, this corresponds to L3-L4 interspace, which is our landmark for spinal puncture. It is for this reason that the lumbar puncture is done at a level below which the cord ends, safest being at or below the intercristine line. The bones of the sacrum are not fused posteriorly in children, enabling an access to the subarachnoid space even at this level. When CSF is taken in lumbar puncture in adults, where is the needle inserted? At the L3, L4 level to avoid any injury of the lower end of the spinal cord. Why? We have already discussed this now. And it is understood now why L3, L4 level is identified and chosen. At this level, there is no spinal cord, only meninges, CSF, and the mobile nerves of chorda equina through which the needle will slip easily. And there is no danger of injury to spinal cord. Now, physiology of CSF. CSF is an ultrafiltrate of the blood plasma. What is the volume of CSF? Total volume is 120 to 150 ml, 20 to 25 ml. Out of this total volume, 20 to 25 ml is present in ventricles, 30 to 90 ml is present at the base of the brain in cisterna reservoir, 25 to 30 ml is present in subarachnoid space. This is our area of interest now. How does CSF formation take place? 50 to 70% of the CSF is formed by ultrafiltration through the choroid plexus, and it is formed around the blood vessels along the ventricular walls. Total production is about 550 ml per day. What about absorption of CSF? CSF is absorbed through arachnoid villi in cranial region, and in spinal region it is absorbed through venous plexus. Now, how is the CSF production controlled? Mostly it is under sympathetic control. Now, this figure shows very accurately circulation of CSF, how the CSF flows from brain to spinal cord. From two lateral ventricles, enter intervertebral foramen, also called as foramen of Monro, enters third ventricle. From third ventricle, it enters fourth ventricle through cerebral aqueduct, also called as aqueduct of Sylvius. From fourth ventricle, through foramen of Magendie, which is the median aperture, and foramen of Luschka, which are the two lateral apertures, enters subarachnoid space. From subarachnoid space, reaches arachnoid villi, where the CSF is absorbed. So this is the full circulation. What are the characteristics of CSF? Now, CSF pressure is different in different positions. In lying down position, it is low, 70 to 180 mm of water. And in vertical position, it is 375 to 550 mm of water. pH is almost physiological, 7.4 to 7.6. Specific gravity, 1.003 to 1.009. Density at 37 degrees Celsius is 1.0003. Now let's proceed to the procedure. First, what are the components of pre-op evaluation and preparation for subarachnoid block? First part before every procedure is consent. So written informed consent. Then physical examination of spine to rule out any anatomical abnormality like kyphosis or scoliosis. Then lab tests are done to rule out any physiological abnormality, any functional abnormality, or any organ system damage like HB, TLC, DLC. Coagulation tests like platelet count, PT, INR, BTCT, blood sugar, RFTs, LFTs, electrolytes. What are the indications of spinal anesthesia? Where is spinal anesthesia used? Surgeries for lower extremities, hip, perineum, lower abdomen, upper abdominal procedures like cholecystectomy, urological endoscopic surgeries like TURP, rectal surgeries, sacral anesthesia are used very commonly, and in obstetrics, in lower segment cesarean section, spinal anesthesia is the mode of choice of anesthesia. Now, what are the contraindications for subarachnoid block? There are some absolute contraindications. First is, as expected, refusal of the patient. Without consent, no spinal. Next absolute contraindication is shock. Skin infection at injection site. Again, systemic infection. Then coagulopathies. Why? Spinal block is never given in coagulopathies or in therapeutic anticoagulation cause of the risk of development of hematoma post-puncture and in cases of increased ICT. There are some relative contraindications also for putting spinal anesthesia. These relative contraindications are cardiac diseases, severe cardiac diseases like ischemic heart disease, neurological diseases, or major spinal abnormalities. Now, let's proceed to technique of spinal anesthesia. First, something about needles. Typical spinal needle consists of three parts: a hub, a cannula, and a stellate. The points of the cannula, they are beveled and they have sharp edges. Cannulas, they are made up of stainless steel and they should be stiff, flexible, and resistant to breakage. What are the different sizes available? 16 gauge to 30 gauge. Most commonly used sizes are 25 gauge, 23 gauge, 26 gauge. As the size increases, the thickness of needle decreases. Needles are classified according to standard bevel with cutting edges like Winky and Babcock, or pencil point needle with conical tip with no cutting edge. These are common tip designs: Winky needle, Whittaker needle, and Sprotte needle. Very important slide. What are the structures which are pierced by spinal needle in sequence when we put a spinal anesthesia? So first structure which we encounter is skin. Next, spinal needle will encounter subcutaneous tissue. Then supraspinous ligament, as it is shown in this figure. Supraspinous ligament, interspinous ligament, ligamentum flavum, dura mater, arachnoid mater. Now, what are the various positions for spinal anesthesia administration? LP is most easily performed when there is maximum flexion of lumbar spine. Why? Because by this the ligaments will get stretched and the intervertebral space will be open. So it will be easy to put spinal in that condition. So what are the favorable positions? Sitting position, lateral position, prone jackknife position. First, sitting position, most commonly used position. How is it achieved? The patient is placed with the buttocks near the edge of the table, legs over the opposite edge, and the feet have to be supported on a stool. The patient can rest his elbows on his thighs, or he can fold his arms forward over a pillow, and neck is flexed. An assistant should always support the patient from the front side, as you can see in this picture. Every effort should be made to see that the back always is vertical, and if it is vertical, only then the spaces will be opened properly. The sitting position is preferred mostly for obese patients and in saddle block, because in saddle block, anesthesia is given depending upon the gravity to anesthetize only the saddle area, that is only the sacral nerve roots. What is the advantage of sitting position? Same that we have told, proper curvature is obtained, spaces are opened properly, so it is easy to administer anesthesia and reach the subarachnoid space. Next position is lateral position. This is a little easy position to maintain. Ideal position, how to achieve this position? The back of the patient, it should be parallel to the edge of the table, and it should be close to the anesthetist, and the knees are flexed up to abdomen and neck is flexed so that chin points the chest. Next is prone jackknife position. This is a very rarely used position and is not a very desirable position as an anesthetist. May be used for rectal, perineal, or lumbar procedures. In this, patient can position himself and hypobaric drug is used. What is hypo and hyperbaric? We'll discuss in later slides. In this, CSF will not flow on its own because gravity is not acting. So CSF will have to be aspirated through spinal needle in this position. Now, what are the landmarks for spinal anesthesia? We should know about vertebral spinous processes and iliac crest. And the spinous processes, they clearly define the midline. First prominent spinous process is spine of C7. Most prominent spinous process is spine of T1. Now T7, how to locate T7? It is opposite to inferior angle of scapula. And the most important landmark for spinal, Tufier's line or intercrestine line, that is the line drawn between the iliac crests. Mostly in adult, it corresponds to L4 vertebral body or L3 L4 space. What are the recommendations for safe spinal technique? First of all, asepsis. Like any other surgical technique, asepsis has to be maintained. So, hands are scrubbed according to aseptic technique. Then, sterile gloves are used. Then, aseptic technique is used while opening the spinal tray also. Before the skin puncture, we need to cleanse the skin properly. Then, after you have worn the gloves, we have to touch only the sterile articles. Then after the skin is cleansed properly, skin is draped properly, needle is directed just under and parallel to the spinous process. Repeated traumatic punctures should be avoided. So in case of difficult spinal, only an experienced anesthetist should make an attempt. Then local anesthetic agents, only the approved agents should be used in standard concentrations to avoid any toxicity or failure of anesthesia. Next is USG guided spinal anesthesia. USG guided spinal anesthesia block is a promising alternative to traditional landmark based techniques. Like all other newer inventions, USG guided subarachnoid block, it is non invasive, safe, simple to use. It can be quickly performed without any cumbersome procedures and does not involve any exposure to radiation. It will provide real life images and without any adverse effects. So, what we need is experienced sonographers. Why? Because they'll be able to visualize neuraxial structures with proper clarity using ultrasound and the understanding of spinal sonoanatomy. It will be clarified properly. So, a scout scan allows the operator to preview the spinal anatomy. Then we can identify the midline properly. We can locate a given intervertebral level and we can also predict the depth of epidural space. And we can determine the trajectory for insertion of needle also. So, ultrasound guided technique can be a very helpful procedure. What are the various approaches for spinal needle introduction? Most commonly used approach is midline approach. So what are the steps in midline approach? First, space is palpated, local infiltration is done, needle is directed just under and parallel to spinous process, bevel is parallel to dural fibers. Two resistances are felt. First resistance is because of ligamentum flavum, then it is because of durameter. Then once the free flow and clear flow of CSF is verified, the drug is injected. Next approach is paramedian or lateral approach. It is useful for arthritic or deformed spine. Space is chosen and the needle is inserted 1.5 centimeters lateral to midline. So called paramedian and at an angle of 25 degrees. Next approach, not very commonly used, Taylor's approach, also used in fused spine or arthritic spine. The needle should be inserted at a point 1 centimeter medial and inferior to the posterior superior iliac spine. Then it is angled cephalic 45 to 55 degrees. It should be medial enough so as to reach the midline at L5 spinous process. After needle insertion, first significant resistance felt is of ligamentum flavum and then durameter is punctured so as to allow free flow of CSF as subarachnoid space is entered. Now, while putting spinal, what are the commonly encountered practical problems? First problem is we are putting the spinal, we feel as if we are in the right position, but there is no CSF. So what to do? First, we have to wait. At least for 30 seconds, we have to wait for the CSF to come. Then rotate the needle 90 degrees and wait again. If still there is no CSF, we have to take an empty 2 ml syringe, attach it to the needle, inject 1 ml of air to ensure that the needle is not blocked, then use the syringe to aspirate CSF. But at the same time, we withdraw the spinal needle. And the point where CSF comes in the syringe, we have to stop and we can inject it. Next practical problem which is commonly seen is blood flowing from the spinal needle. So what has to be done? First, we'll wait. We'll wait till the CSF becomes pinkish and then completely becomes clear. But if blood continues to drop and the CSF is not becoming pinkish and white, then you withdraw the needle and space should be changed. Next practical problem is patient complains of sharp stabbing leg pain. The needle has hit a nerve root. That is why the patient is complaining of leg pain. So what should be done? We should withdraw the needle and redirect it more medially away from the affected side. Another problem is whenever needle is directed and whatever directions I'm changing, whatever depth I'm changing, I'm encountering bone. It seems that I'm striking bone again and again. So what we have to do, we have to make sure that the position is made correctly with as much as lumbar flexion as possible and the needle is still in midline. So even after correcting these things, still we are striking bone again and again, then it is better to use paramedian approach. Now, various factors which are postulated to be related to spinal block height. First is age. How does age change the block height? Spinal and epidural space, they become smaller with increased age. So, higher distribution of drug and higher level of block may be attained with the same drug. Next is obesity. Obesity, pregnancy, all these are conditions of increased intra-abdominal pressure. When intra-abdominal pressure is more, it will result in increased epidural space pressure and thus decreased size of the space and hence higher level of block. In spinal curvature, basically spinal curvature, abnormal curvature has no effect on technical aspects. Position will matter greatly. In cases of hyperbaric solutions in sitting position, they cause the solution to gravitate into caudal areas. Next, how does the rate of injection affect the block height? In cases of slow speed of injection, low level of anesthesia is attained, and in cases of rapid injections, high level of anesthesia is attained. Volume, dose, concentration. Most studies show that there's no effect of volume or concentration on the block height, and it is difficult to change one factor alone. Baricity. Now, what is baricity? The ratio of density of local anesthetic solution divided by density of CSF. Depending upon this ratio, a drug is classified as isobaric, that is having the same specific gravity as CSF, hypobaric, as specific gravity less than that of CSF, hyperbaric, specific gravity more than that of CSF. So a hyperbaric drug, how to make a hyperbaric drug? Dextrose is added to local anesthetic. Isobaric, saline is added. Hypobaric, distilled water is added. What is the effect of gravity on these drugs? According to the gravity, hyperbaric solution will tend to settle down. Hypobaric solution will move opposite to gravity, whereas isobaric solution, it will remain at the site of injection and it is not influenced by gravity. So what are the conclusions? Conclusions is if you make the patient in head down position, then hyperbaric solution will move cephalic, so more height of the block. Hypobaric solution will move caudally, so lesser height of the block. If we make head up position, so hyperbaric solution, vice versa, hyperbaric solution will move in caudal direction, hypobaric solution will move in cephalic position. In lateral position, as expected, the hyperbaric solution of the drug will move in the dependent area. So it will anesthetize more in the dependent area. And it opposite will take place in hyperbaric solution. Whereas in isobaric, they will stay in their area of injection regardless of the position. So gravity does not impact any isobaric solution. Site of injection, the level that you place the local anesthetic it will influence the spread of local anesthetic. So if we place our medication at L2, it will cover obviously higher levels than if you inject it at L5. This is a technique called barbotage. Barbotage, it was described by Bayer. And what is it? It consists of injection of anesthetic solution into the subarachnoid space, like spinal we are giving. Then we have to immediately withdraw a portion of the solution and then re-inject it. So this has to be repeated a number of times. This will induce a to and fro movement in the drug, and it will agitate the injectate. And the currents that are generated, they will make sure that the drug is more completely and more effectively mixed in the CSF. So this is a technique, but caution must be observed, and each operator, while performing barbotage, must learn the results of his barbotage. This is a slide showing different segmental levels corresponding to the areas like perineum S1 to S4, inguinal L1, umbilicus T10, nipple line T4. At the same time, segmental levels of spinal reflexes are epigastric T7, T8, abdominal T9, T12, cremasteric L1, L2, plantar S1, S2, knee jerk L2 to L4, ankle jerk S1 to S2. Depending upon the type of surgical procedure, we have to determine what segmental level block we have to achieve. For example, if we have to give anesthesia for upper abdominal surgeries, then the desired block height should be at T4, that is at the level of nipple. Similarly, for intestinal surgeries like appendicectomy. See, appendicectomy has a star at its end. That means appendicectomy, there's a word of caution. That is, blockade to T10 is not adequate for appendicectomy as it is expected. Why? Because of splanchnic supply to peritoneum, T6 to T1 or T6 to L1. So for appendicectomies, a blockade level up to T6 to T8 is required, along with ureteric surgeries, along with renal pelvic surgeries. Similarly, for transurethral resection or vaginal deliveries or hip surgeries, level up to T10 or umbilicus level is adequate. Similarly, for foot surgeries, L2, L3 level is sufficient. For perineal surgeries, S2 perineal level is sufficient. Now, what is the order of the block? Autonomic fibers, they are the most sensitive. So, they are blocked first. Then sensory fibers are blocked, and in the last, motor fibers are blocked. Autonomic fibers are more sensitive. Why? Because they are smallest and non-myelinated. And how these fibers are tested? Autonomic level is tested by temperature. Sensory level is tested by pinprick method. Motor fibers are tested with lower limb movements. So first we have to check temperature, then pinprick, then lower limb movements. Differential block. Why is it called differential block? Because sympathetic block is attained 2 to 6 dermatomes higher than sensory block, and motor block is achieved 2 dermatomes lower than sensory block. So if we get a sensory block at T5, we'll get a sympathetic block higher than T5 and a motor block lower than T5. So what is the sequence of nerve modality? What is the sequence of events that will happen with the patient according to the nerve fibers that are blocked? First, there is vasomotor block. So there is dilatation of skin vessels, block of temperature fibers. Patient will feel a sensation of warmth in the lower limbs. Next, temperature discrimination is lost completely. Then slow pain is lost. Then fast pain is lost. Then tactile sense is lost completely. Lastly, motor paralysis occurs. Patient is not able to move limbs. To check complete or incomplete motor paralysis, we have a score called modified Bromage score or modified Bromage scale. Depending upon that, we grade the attainment of motor block. And in the last, pressure sense and proprioception is abolished. This is the sequence while attaining the anesthesia. Whereas during recovery, anesthesia recedes from head and feet areas towards the middle. That is the point where anesthetic agent was injected. There, the analgesia will last up to the last time. Now, what are the indirect effects of spinal anesthesia? Sympathetic blockade is the major determinant of physiological responses. First response is hypotension. What are the various causes of hypotension? First is paralysis of vasoconstrictor nerve fibers, arteriolar paralysis, venous dilatation, vasodilatation causing decreased venous return and hence decreased cardiac output. Next is direct action on medullary centers. Other causes can be loss of skeletal muscle tone or paralysis of nerve supply to adrenal glands, which lead to decreased catecholamine release and hence decreased sympathetic stimulation. Next effects are cardiac effects. Heart rate slows down. Why? Because of paralysis of cardioaccelerator nerves, decreased venous return, which leads to decreased right heart pressure and hence decreased heart rate. This is basically Bainbridge reflex. Normally, what happens, baroreceptors, they respond to fall in blood pressure by tachycardia, Mary's law. But in cases of spinal anesthesia, Bainbridge reflex predominates. So, hypotension is not accompanied by tachycardia. Instead, hypotension along with bradycardia occurs as a side effect of spinal. Next effects are respiratory effects. Vital capacity may decrease, decrease in expiratory reserve volume related to paralysis of muscles. They may be necessary for forced exhalation. Respiratory arrest can also occur due to hypoperfusion of respiratory center, which is caused in cases of high or total spinal anesthesia. Peripheral pooling of blood. It results in decreased alveolar blood supply, which leads to decreased O2 supply and hence reflex bronchodilation. Last indirect effects are GI effects. In gastrointestinal system, sympathetic block and parasympathetic overactivity can lead to increased peristaltic activities, increased gastric emptying, increased segmental movements. Therefore, postoperative period of fasting is enhanced generally after spinal so as to avoid paralytic ileus, and patient is kept nil by mounts till effect of spinal weans off. What are the various endocrine effects of spinal anesthesia? Spinal anesthesia is able to block the sympathetic stimulations which are caused by surgical stress. So, blockage of these sympathetic afferents, they will prevent any increase in plasma prolactin levels, growth hormone, ACTH, ADH, which are basically stress hormones. In genital system, there may be flaccid paralysis of nervi erigentis and engorged penis. Vasodilatation, because of spinal anesthesia, it may cause heat loss at the site of block, which may induce shivering in the patients. As far as renal function is concerned, neuroaxial blockade has little effect on blood flow to renal system. Mainly, autoregulation maintains adequate blood flow to kidneys as long as perfusion pressure is maintained. So basically, hypotension has to be avoided so as to prevent any damage to the kidneys. Neuraxial blockade, they effectively block sympathetic and parasympathetic control of the bladder at lumbar and sacral levels. Urinary retention can occur. Urinary retention can occur as a side effect due to the loss of autonomic bladder control. So the normal function of bladder does not return until sensory function returns to S3. Now, some words about subarachnoid block in neonates, infants, and children. Spinal anesthesia in children does not produce any hemodynamic instability. Why? Because of small venous capacitance of lower extremities in children and immature sympathetic autonomic nervous system in children. So, spinal anesthesia can be a beneficial mode of anesthesia in children. And indications are lower abdominal, pelvic, and lower limb surgeries. Hyperbaric 0.5% bupivacaine can be used up to T4 level of anesthesia. What is the dose of bupivacaine? For premature infants, it is 1 mg per kg. For full-term infants, it is 0.8. And for small children, it is 0.5 mg per kg. However, there are some complications associated with spinal in children. Mostly they are related to technique. It is technically difficult to put spinal in children. So there is higher failure rate. Plus the duration of block is also small. So let's enumerate some beneficial effects of spinal anesthesia. They can be said to have following advantages over epidural. What are the advantages? Spinal anesthesia is easy, it is quick, and it provides slightly better relaxation of abdomen. Whereas in epidural anesthesia, it is a little lengthy procedure, and the onset of analgesia by epidural anesthesia is slightly long. So we have to wait longer. Surgeon has to wait longer in case of epidural anesthesia. Plus, the danger of toxicity to the drugs is negligible in spinal. Why? Because spinal mostly is a single shot technique and smaller doses of drugs are required. Whereas in epidural, larger volume of local anesthetics is required. Now, next are advantages of spinal anesthesia over GA. First, obviously, it is cost effective. Spinal anesthesia is cheap. Lesser amount of drugs, lesser modalities, lesser equipments are required in spinal. In spinal, it obviates the need for GA, which may be problematic in some patients. How? For example, in spinal, spontaneous respiration is maintained along with good abdominal relaxation. So, especially in patients with respiratory diseases like COPD, asthma, general anesthesia can be very problematic, can be very threatening. So, spinal anesthesia is very beneficial. As in spinal anesthesia, there is no need for intubation. So, all challenges of airway management and tackling difficult airway, they are obviated. Next, there is reduction of surgical hemorrhage, for example, at prostatectomy. In spinal anesthesia, there is decreased incidence of thromboembolism because of early ambulation possible. Some disadvantages of spinal over GA. First point can be discomfort, especially if the procedures are very long. Discomfort eliciting paresthesias. Spinal anesthesia is contraindicated in confused patient. Now, if the patient is not neurologically stable, spinal anesthesia is not a very good choice. Then, if the patient has profound cardiovascular effects, then mostly GA is preferred over spinal because of indirect cardiovascular effects of spinal anesthesia causing profound hypotension, profound bradycardia, profound decrease in cardiac output. Other side effects of spinal anesthesia can be leg weakness, urinary retention, toxicity with high serum levels of anesthetic drugs, or accidental IV injection. Accidental intravenous injection of local anesthetic can be life threatening, and it is termed as last local anesthetic systemic toxicity. Then, poor communication of intentions if the patient is not cooperative or if the patient is deaf. Thank you very much.